WhatsApp 287-0971. Our Rev-Up office numbers are 572-0383 and 572-0215. Rev-Up St. Lucia, the alpha of radio.
Join Dr. Leonard Suraj on Rev-Up St. Lucia 97.1 FM Tuesdays from 6 p.m. to 7 p.m. for Doctor in the House. This 1-hour discussion call-in program delves into the science of various diseases, treatments and medical processes, and offers in-depth explanations to empower listeners and help ensure a better understanding of healthcare for all. So tune in on Tuesdays from 6 p.m. to 7 p.m. for Doctor in the House with Dr. Leonard Suraj, only on Rev-Up St. Lucia 97.1 FM. Doctor in the House, brought to you with the compliments of Tapia Hospital.
Tapia Hospital Radiology Department offers 24-hour service. We provide you with X-ray, CT scans, and ultrasound imaging using the most modern equipment that produces the best images for your medical attention. Call the Radiology Unit at 459-2201. Tapia Hospital, where the patient's safety comes first.
Time now for Doctor in the House, live with Dr. Leonard Suraj. Dr. Suraj, a very good evening to you.
Good evening, Andre, and good evening, listeners and viewers, live on radio and streaming live on Facebook and YouTube. Today, the 8th of April, and 2025, the years and the months are going so fast, it's amazing. However, today we have a special program on venous diseases. Not venous like in Mars and Venus, but it is the blood vessels. You know, we have arteries and veins, and we always think of the arteries because of strokes and that kind of thing. We pay little attention to the vein. But the vein is so important that WHO has assigned a day just to acknowledge the presence of the disease processes of the veins. And I have with me two people who are, one of whom have been here before, Dr. Charles Greenidge. He is a vascular surgeon, a general surgeon with a lot of expertise, being trained overseas, and now has been with us for about a year or so. And a lady who is Mrs. Crystal Richards, and she is the wound expert, and she knows how to take care of wounds painlessly. So the discussion today would be essentially to look at issues with the vein, what are the problems, common problems, how we deal with it, and I think to a large extent how do we prevent it, because we've always said picking up things early and prevention is the best part of trying to get on top of the disease. So everybody, welcome, and let's get the ball rolling.
Thank you, Doctor.
Welcome, everyone.
Yeah. So, tell me, what are the more common issues you find with the vein?
Okay, so first of all, Leonard and Andre, thank you very much for inviting myself and Crystal to the program. I'd spoken to Dr. Suraj some time ago to say that there is an association of vein specialists throughout the world, and in order to try and focus on, as you said, venous disease tends to be a bit of the Cinderella of vascular surgery. Everybody talks about arteries and bypass and so forth, but sometimes the veins tend to be neglected, and the organization has a week of activities which starts on World Health Day, which is the 7th of April. So we in St. Lucia, we decided to participate in the celebration. And today we had a workshop where 2 of our doctors and 2 of our nurses came to us at Bay Medical Center, and myself and my clinical assistant, Mrs. Richards, we basically discussed and went through various issues to deal mostly with venous disease, but also one of the issues of venous disease, which is leg ulceration. So we had basically a situation which covered the majority of what you can expect to see with venous disease. Venous disease has a big price to pay in terms of the morbidity and mortality that it produces in the population. I think we all know about the life sore. The life sore is one of the really unfortunate issues that can occur with venous disease. We have varicose veins, which can be annoying, and but the ulcer that results from chronic venous disease is really a difficult issue to manage. It's very, very hard on patients. It often leads to a lot of pain, suffering, lots of visits to the doctor, lots of dressings being required, little success with certain doctors, and you end up doctor shopping. You may find yourself in unconventional corners trying different things. Very, very frustrating. Can often lead to loss of days at work, and can even lead to loss of employment. In fact, one of the patients that we treated today, actually we met through the National Insurance Scheme, because she was referred to us because she was having such severe pain at work that she literally could not work. And she'd taken so much sick leave over the years that her employer sort of asked, you really need to consider being labeled, it's an unfortunate word, invalidity benefit.
It has its own meaning.
Yes. That's such a harsh word on its own.
Yeah.
But something as simple, if you wish, as venous disease can lead to an ulcer, which can lead you to be classed from the National Insurance Scheme as an invalid.
But there's something else I would like to put into this, and that is quality of life.
Yes.
Because we look at, you can be alive, but you have poor quality of life.
Yes.
And so therefore, I see these diseases as seriously impairing your quality of life.
Yeah. And this is something that I guess, as surgeons, Leonard, we tend to be very matter-of-fact with a lot of things. But that is really, really important, because if you're spending all your time in pain, all your time having to do dressings, sometimes the wounds are actually foul-smelling, leaking. So how do you go to work? How do you sit next to people? How do you go to the market? These things are not easy.
And people tend to avoid you.
Yes.
Yeah.
Yes.
You in turn avoid people because of the embarrassment of, the smell, and having to constantly be conscious that there's something wrong with you. And most of these ulcers, the bandages are not easy to cover up, because you have a bandage that's coming from your toe all the way up to your knee. And a lot of, the women who have to endure this, they can't wear nice things. They can't wear what would make them feel pretty. They would have to wear like long skirts and baggy pants. So it really does take a toll on your confidence. It's not just about your health. You want to take care of it, and because sometimes that kind of, you get in your head about that, and it gets in the way of you actually being a productive member of society, because you can't go to work. You can't stand up. It's very painful, and you have to stay home. And then sometimes you're home, and even your family members at home kind of distance themselves because of the smell. It's a very difficult condition to manage.
That's right.
Yeah.
But regarding the pain, I just want to put, during medical training, you don't have much about the pain. You hear about how it happened and how we take care of it, etc. But the pain is a real important factor, isn't it?
It is. I can't give you statistics, but most of the patients don't have pain.
Okay.
They have some discomfort, but some of the pain. Well, okay, let me rephrase that. That's bad use of English. They have pain, but if you grade the pain out of 10, they might tell you 4 out of 10, right? But every so often you'll have patients like the lady we saw today. She has 10 out of 10.
Wow.
And she's a chef. So she's on her feet, up and
All
down,
the
up
time,
and
yeah,
down,
yeah.
right? The lady is telling us today, she's so busy, she doesn't even get time to eat. Most of the time, she has her breakfast, she packs her lunch, and she takes her lunch home.
Okay.
Right? So
yeah.
they're so busy. And she just can't bear it. It's so painful. So some patients do get a lot of pain, and they're particularly difficult to treat.
So the condition you're speaking about is the long-term, the life
The
sore.
ulceration, yes, the
okay,
life sore.
ulcer, yeah.
Yeah. Patients who don't have ulcers don't tend to have like that 9
Okay.
out of 10 pain.
And it tend to weep, don't it?
They do.
Because of the gravity
Right.
effect.
So because of the standing, the legs become edematous, swollen with fluid,
Fluid
and of
energy.
course the skin is a barrier. But if you have an ulcer, that
Right.
barrier is gone. So literally it's like the cartoon, you know, when the fella gets shot and then they drink something and the water comes out like a watering can.
Yeah.
I mean, basically it's the same thing, you know. The
Yeah.
ulcer will allow the fluid to come out.
To escape, yeah.
So, and that's one of the challenges where if you're doing dressings, then you have to try and find materials that can absorb a lot of water. Other than that, you know, and of course, as Crystal said, from the time it comes wet, it becomes smelly, and then the patient becomes upset. They want to avoid people want to avoid them, and it's a vicious cycle.
And you know, a fly can smell that from a mile away.
Yeah.
So in no time, 1 or 2 flies pass
Oh,
around.
yeah, it
And
happens.
then it creates an embarrassment.
Yes.
It creates people try to avoid you and that kind of thing. So it's a life that psychologically we really have not looked, or maybe they have, but I'm not aware of it. The psychological impact on that kind of illness.
Mhm.
Okay, it basically shuns you.
Yes.
And the people who shun you may not mean unwell for you.
No.
It's just that the natural way people react to things.
Yes. And so it's something that we really want to make sure not only the public but medical professionals as well, because because it's not a sort of glorious dynamic part of medicine. You're not necessarily seeing a lot of people gravitating to that. So, but we want to make sure that people understand what the problem is and address the treatment, because it can be treated pretty easily.
Okay.
What was the word? It's easy but difficult. You know, it's not complicated, but it's difficult because it has to be a conscientious application of you know, history taking, examination, diagnosis, which might include testing like ultrasound. But once you've made the diagnosis, then you know there are different avenues.
So what are you
to treat.
testing in the ultrasound?
So in the so first of all, the ultrasound is really revolutionary. And
Okay.
we were talking about it today, and I was saying that, you know, we do actually need more and more to bring ultrasound into the doctor's office,
Okay.
right? Because this is something which I have done recently by the encouragement of my colleagues, and it is really fascinating when you're not just reading a report now, but you're actually using the ultrasound to answer your questions literally live. So it's become a very exciting endeavor for me. You know, I guess one of the things about medicine is that no matter how much you know, you still don't know very much. So you can always keep yourself interested by learning more. What the ultrasound does is that it can actually tell you where the issue with the vein is. So we can apply compression therapy, which is a bandage which is being used to compress the veins and therefore correct the imbalance that exists. But with ultrasound, you can now actually see where the problems are, and you can direct therapy to those spots. So instead of using a kind of, you know, broad-based approach, you can now be quite specific with your treatment. And more recently, I mean, you'd remember back in the days when we were medical students at QEH, we used to talk about stripping.
Yeah, vein
Right?
stripping. Yeah.
So you know the problem is this vein that runs on the inside of the lower limb, and the surgical operation was basically to pass a wire up, tie it, and strip it out.
Mhm.
And when you think of that operation now, compared to what we can do now, it's like night and day.
Mhm.
So now we're not going to strip the
The vein.
vein.
So the stripping of the vein is not something that is currently encouraged.
I wouldn't say it's not that it is discouraged. It's a good operation,
Mhm.
but it is. I guess it. If you think of having to operate on somebody and open up the entire belly to
It's a
fix
bit,
something,
it's a bit brutal.
is a bit brutal. I mean, it was appropriate for our
Mhm.
knowledge and technology at the
Mhm.
time, but the technology has changed so much,
Mhm.
and understanding has changed so much.
Yeah.
So
yeah.
something that you would have had to do with an operation under general anesthetic, making
Mhm.
cuts in the groin and cuts in the leg, you can now do with a laser fiber, for example.
Mhm.
So you can make a small puncture and pass the laser fiber up
Mhm.
the vein. Issue with laser fiber, it's expensive technology, which reflects as an expensive treatment.
Mhm.
But there are now much more inexpensive approaches where you can either use small incisions, so you
Mhm.
can make really tiny, like 1 centimeter incisions on the
Mhm.
spot where the problem. So having done the ultrasound,
Mhm.
you can identify the vein with the problem is right here.
And the problem in the vein would have been
So would be the valves.
the valve that
So
has burst.
what happens, like for example, in a post deep vein thrombosis situation, the
Mhm.
valve to the vein gets damaged,
Yeah, yeah.
and in damaging the vein, you
Mhm.
damage the function,
Right.
and that leads to high pressure in the leg, which can then lead to ulceration.
Yeah. Mhm.
So,
Okay.
but this thing is not silencing. Okay, finally got it.
Got it.
So now that we're able to identify the spot with ultrasound, we
Mhm.
can make either small incision, or you can place the laser fiber at that particular point.
So are you creating a valve or you just
You're not
condemning that
creating a
piece?
valve, but you're eliminating that spot that
Mhm.
is leaking.
Okay.
So the nice thing about the venous system is that there is plenty of reserve. You know,
okay.
there are lots of ways to get the blood to go in the right direction.
Mhm.
But if one of the veins is not functioning,
Mhm.
then it reroutes everything in a circle.
Mhm.
So you find a situation where instead of all the blood going nicely up towards the heart, the blood goes up and then comes around, goes down, comes back up again. So instead of forming a nice directional flow,
yeah.
you have this shunt. Where-
Shunt, yeah.
Yeah, where like a circuit where the blood is just going in circles.
And this blood is very low in oxygen.
It's very low in
Yeah,
oxygen.
and that's the
it's not
problem.
going anywhere.
Yeah.
So of course the leg becomes swollen.
Mhm.
The blood is not leaving the leg as it should, so the pressure
Mhm.
builds up. And then of course the nutrition
Mhm.
to the skin, especially where it gets the most effect, which is down by the ankle. Because you know
Mhm.
when you're playing football and you get kicked in your shin, you know about it, right?
Yeah.
Because there's no protection. It's just skin and bone.
Yeah, skin and bone.
So there's no like fatty muscle tissue down there.
Mhm.
So you find that's why leg ulcers tend to occur in that spot.
Okay.
Because it's very vulnerable. It
Mhm.
has very little support.
And very little blood supply. Yeah.
Mm-hmm.
So basically, what I'm hearing there is that in the whole scheme, we can go into details with it, but just for the purpose of clarity, what we are saying is that you have a heart that is pumping blood to arteries that go to all the organs, to the heart, to the lung. So the heart is pumping the blood. The blood is being used by the tissue and coming back to the heart for pumping again, but passing through the lungs to reoxygenate it.
Yes.
Right. So, but somewhere, especially in the lower limbs, the blood has difficulty getting back through the veins into the heart to pump it to the lungs to replenish the oxygen. So you have a situation where the legs, the veins in the legs are not circulating the blood unable to allow the blood to come up. It just
Correct.
remains stagnant. And all the issue we're talking about is related to this vein not working properly
Yeah.
and over a long period of time and harboring a lot of low oxygen type of blood and causing all the issues that we have.
Yes.
Yeah.
Exactly.
Okay, so apart from the leg ulcer that you mentioned, what are the other problems the vein can have?
So the other thing is varicose veins, and varicose vein now creates a lot of it is, as Crystal was alluding to, the more cosmetic appearance, and of course the ladies tend to be more affected by this. So you get veins which then are very visible. They tend to be tortuous, a bit unsightly, and
They're like big lumps in the back of your leg.
yes,
Right. And you can see the smaller ones popping up. Yeah, I've seen that.
yes, and the ladies especially, they don't like it because it affects their, as you say, their morale, their confidence. It restricts the kind of clothing they can wear because, you know, people will notice and want to ask questions and so forth. So they tend to be more conservative in their dress, which is not how they want to express themselves. So we do see ladies who come, so they don't necessarily have major symptoms of pain or swelling, but because of the bulging of the vessels or the discoloration, because sometimes the veins are actually very, very small, very sort of almost the diameter of a hair, but they have a very blue color, and again, it tend to occur around the knee,
Right.
and that's just not okay.
So, yeah, so what causes these veins to pop out like that?
So again, it's the same issue with the veins not functioning properly, the valves in the veins not functioning properly. Sometimes it can be related to hormones. So again, why it tends to be more common in women.
Okay.
And so the veins can dilate under the influence of estrogen. And they're very thin. Some of the veins are very thin, so you can actually see the deoxygenated blood in them, which hence gives you this blue
color.
discoloration.
Yeah. Because oxygenated blood is red.
Yes.
Or more red
Yes.
than the blue one. Yeah. Okay. And so with varicose veins, how do you manage that? How do you treat these varicose veins?
So the treatment basically is the same. What we tend to do is again ultrasound to determine where the issue is. We can control a lot of the symptoms using graduated pressure stockings, and you were talking again about prevention.
Yeah.
So the knowledge that if you're in a job where you're standing a lot, like you know, for example, if you're a chef or a teacher, knowing that you're standing a lot and that maybe your mother or your brother, somebody had varicose veins, that you are liable to have them as well. And prevention would be using hosiery that offers pressure to support the veins and prevent the varicose veins.
Yeah, because when the blood is trying to leave the legs and going back to the heart, it is under the gravity pressure.
Yes.
So therefore, that if the vein, and the reason why the blood only travel up in one direction is because the valves prevent it from going back.
Going back down, exactly.
Yeah. So if you don't have the valve, you expect it to pull back down to accumulate
Correct.
in the lower part.
Correct.
Okay.
So if you're wearing stockings before you develop varicose veins, then that destruction of the valve by constant standing,
Yeah.
because basically when you stand, the stagnant blood on the valve causes inflammation and ultimate destruction
Okay.
of the valve.
Okay.
So if you have the support stockings, it basically keeps the circulation going and prevents that stagnant inflammation from occurring. But of course, a lot of our patients will come after the fact.
Yeah.
You know?
And I think the The importance of these programs, especially for educational program, is to alert you of the things that can happen if you didn't take the appropriate action.
Correct.
And so I think a lot of emphasis will be put on prevention as we go through the program. But I just wanted to identify the major venous diseases that we have, that we are seeing in our society, and how do we manage it, and how can we improve on the management.
So as you said, knowing that this is a risk in certain professions, or because of your genetics, we would definitely advise you, to wear support hosiery, which is not only stockings; they have socks for the men as well.
All right.
But which will supply support for you while you're spending a lot of time standing, and just general knowledge about the fact that it's a good thing to walk. So if you're in a job that has you sitting or standing for long periods, to break it up by walking, because when you're still, the veins ultimately relax and open, and then that pressure gradient of blood from the heart down to the feet exists. But as soon as you start walking, then the valves will open and close, and they'll break that hydrostatic column, if you like.
And the soleus pump.
And the soleus pump will push the blood back up in the correct direction.
Because if you have a bandage that prevents the blood from stagnating, and then you have the muscle pumping the blood away, it has to go one direction.
It has to go one direction.
Yeah, and that's going up.
Yeah, so realization of that. So you do more walking, and of course if you get an opportunity to put your feet up, like maybe in your lunch break you get a little opportunity to put your feet up on the desk or whatever, that can be really helpful.
So from what you're saying, it seems as though standing and not walking is more dangerous. I don't use the word dangerous. Is more likely to create venous issues than if you are actually standing and walking.
Correct. Because if you're standing and walking, then as you said,
the pump,
you're constantly pumping. First of all, you're breathing.
Yeah.
A little more deeply.
More oxygen goes in.
Every time you breathe, you get more oxygen, and you reduce the pressure inside the abdomen, which facilitates blood moving from the foot into the abdomen, and then of course on towards the heart. By walking, again, the valves are now being activated, so they're actively opening and closing.
Right.
So that makes a huge difference to the what we call the pressure in the limb. So you can have. So we're not talking about blood pressure. We're talking about the pressure actually in the tissue. So if you have venous dysfunction, if you actually measure the pressure in the tissue, in the leg,
pressure,
it's much higher than it should be.
It's
much higher than it should be.
There's a backflow. That prevents it, and prevents the blood from that. The blood leaves the tiny capillaries. Leave that, because you have the artery. Say, let's talk about the arterial side. You have the artery, and you have smaller arterioles, and get smaller and smaller until you get a little vessel that's so small it is one cell thick. And fluid and other particles can escape through the cell or through the gap between the cells. And get into the tissue. That's what they call the interstitial tissue.
And all of this movement is directed by pressure.
Right.
So if you have a high intravenous pressure, then that pushes the fluid from inside the vein outside into the interstitium, and that's why you get this swollen leg.
Okay, because the fluid,
because the pressure is pushing it out. But the pressure shouldn't be so high. The pressure should actually be very low in the vein.
Right.
And so that fluid that wants to accumulate actually goes from the tissue into the vein, and of course then goes back to the heart. So that's why pressure hosiery, or even bandaging, if there's a necessity because of an ulcer, will actually facilitate the proper movement of fluid from the tissues into the vein and then back to the heart.
Okay. All right. So
Okay, before we continue, let's
Yeah.
just take a little break. Remind our listeners and viewers that this is Doctor in the House live on 97.1 FM, also on Facebook and also on YouTube. Brought to you the compliments of Tapia Hospital.
Tapia Hospital's pharmacy is always well stocked to meet all your prescription and healthcare needs. We also offer specialty drugs for cancer patients and for various other medical conditions. Call our pharmacy at 459-2400. Tapia Hospital, where the patient safety comes first.
Welcome back to Doctor in the House, live with Dr. Leonard Suraj. Dr. Suraj, is back to you.
thank you again, and welcome everybody back again. We were discussing the vein. I have with me Dr. Charles Greenidge and Mrs. Crystal Richards, who are involved in wound care. And now we are dealing this evening predominantly about venous diseases, vein problem arising from the veins, leg ulcers, these chronic leg ulcers you see people have. So we are discussing that and the way forward on treating these areas. All these, many of them become wounds that have been there for a long time, and it's a tremendous challenge to actually cure these things. So we're back again, and yes, so we're talking about, you want to talk about the wound care?
Wound care.
Yep, okay. The expert on wound care is just next to me. So tell me a little bit about the challenges you have with wound care, and what would you like the general public to know about the way you deal with the wound care.
Okay, so one of the many challenges that we face is patients coming in when the wounds have already been there for a very long time. So we have patients who have come in when the wound just opened up, like it starts off as a little pimple, and then they notice that there is something there, and it gradually gets bigger. But the thing is, it goes from 0 to 60 in a matter of weeks. So most times when patients come to us, it's already bad.
Okay.
So these wounds, when they start off, initially they start off very small. Like I said, they start off as a pimple, and then it has a little scab, and then they pick at the scab, and then it just develops because they're not wearing stockings. They don't even know of the conditions that they have. They just see it as a sore. So of course you go to the health center and they look at it and they say, okay, well, they put on a dressing, and it gets worse with time because they're not treating the problem. They're just treating the wound until they know what the diagnosis is, which is most probably venous insufficiency. Then it will just continue on like that. So the lack of knowledge is one of the problems that we have.
And lack of knowledge on the part of the person with the wound, and also on
I
the
was
person.
expecting that.
And also on the person who is treating
Yes.
the wound. Yes.
Yeah.
So proper diagnosis is very, very vital to even the beginning of the treatment of these chronic wounds. And it is possible for those wounds to heal. So not everybody will say that they've had an ulcer for 20 years or I've had an ulcer for 10 years. If they catch it early, prevention, once the wound heals, we inform them that they have to start wearing stockings and everything that they need to do in terms of prevention and support for their veins, because that's what the real issue is. It's the veins. So once we get to that aspect of it, the patients generally, they come in and they're receptive to the information given.
By the way, when you say they come in where? Where is that?
Come into Bay Medical Center. When they're referred to us, most patients are referred by family members who have been seen, doctors that they visit, and they refer them to Dr. Greenidge at Bay Medical Center, who is the venous specialist on the island. So he would diagnose and we would treat the wounds. So the dressings would be done depending on...
So this, assuming the person knows exactly what they have, this sort of treatment is not available at a healthcare facility like a health center? I mean, is it that it must be at the center that you refer to?
No, that is not what I'm saying. It can be treated at a health center. If they know what they have, the health centers, they do have people who are trained to deal with wounds. But like I was saying, it's not really about the wound. It's the condition. So we're treating the wound. So at the health center, they would treat the wound. But at Bay Medical Center, we're treating the disease, which is venous disease. So in as much as like basic wound care is necessary, you need to get to the underlying problem. The underlying problem is not the ulcer. The ulcer is the cause. It's an effect of
the
what
problem.
the problem is, which is, the veins.
Yeah.
So once you're treating the veins, if you treat the veins, then you can prevent the ulcers. So if you have poor circulation, which is what we generally call it when they tell you your legs are getting dark, your feet are cold, and you have a sore that's not healing, generally they say you have poor circulation. If you're diabetic, that's what it's leading to. Not that there are not diabetic ulcers, but diabetic ulcers can also be a derivative of venous ulcer. So it's a chronic wound. So we treat that. Dr. Greenidge is the one who would treat the veins themselves. So the procedures that he was talking about earlier, like the vein stripping and sclerotherapy, which we also do to treat spider veins and varicose veins. So the wounds themselves, when it's really bad, it's horrible for the patients because it's painful. And patients who have chronic wounds, who work in areas like being chefs, teachers, hairdressers, barbers, people who are on their feet for an extended period of time, and they're standing most of the day. Even people who work in stores who, they don't really get breaks and they have to walk the floors, they're on their feet all the time. Tellers are sitting, but they're sitting with their legs hanging down. So we do have like a wide variety of occupations that's hazardous to people who have venous insufficiency. So when they come in and they have the chronic wounds, we start to treat the wounds by cleaning and sometimes debriding, if it's very sloughy, if it's very dirty, if it's smelly. So they are basic wound care things that we do in the office to help the wound heal. But the main thing is treating the condition, which is the venous insufficiency.
So at what point would the person say, okay, somebody goes to a health center,
Right.
okay, and they think that this is just an ordinary pimple or whatever you said earlier. At what point does the healthcare provider realize that this is something serious and that person now needs to see a professional? At what point? Or is it that they're ill-equipped to do that sort of thing?
So I think Andre, what we're saying is that fortunately you don't need a lot of sophisticated equipment to adequately treat a venous wound. But a lot of us tend to focus on the wound as opposed to the patient with a wound, which is a totally different situation. So when you have a wound, it might be sloughy, it might be dirty, it might be infected. If you focus on the wound, then you're not going to get the results that you really want. What needs to be done is that we need to focus on the cause of the wound. And I think that is what Crystal is speaking about. So it's not that if you go to the health center or if you go to Bay Medical or whatever, the approach has to be the same, but the approach is often not the same. So it is important, and in fact, as I was saying earlier, we had a workshop today.
Sorry, Dr.
That's
Greenidge.
okay. We had a workshop today.
Sorry, I'm a little lost.
Yeah.
I'm saying, okay, somebody is at a health center thinking that all they have is some minor pimple or something like that. Right? I'm asking because this is really important. They're not aware that they have a serious problem or what could develop into a serious problem.
Yeah.
So the person at the healthcare facility may not be able to diagnose the problem. They may not even understand what's going on, but they're thinking that they're treating the issue.
Yes.
So I'm asking, how does the person at the healthcare facility that is treating this wound, how do they know that it's time for this person now to seek proper care or to find out exactly what's going on?
Well, I think like most of us, if we're presented with a problem, we make an assessment and we start treatment. If the wound isn't responding as we would expect it to, if it's not getting better, then you have to start asking yourself, okay, well, I think I need to speak to somebody about this. And I mean, this is something that we do as medical practitioners. I mean, Leonard and myself, you know, we'll be confronted with a problem that we say, well, okay, I think this is what is wrong. This is the appropriate treatment. Hold on, but this thing is not getting better. So you have to, as a health professional, you have to say to yourself, maybe I'm not considering something here, and then you go on to discuss it with someone who you feel might have more answers, because you know, as a general physician, you, especially if you're a doctor working at the health center, you're a general practitioner. You know, you're looking after all kinds of different problems. You are not necessarily going to be an expert in everything. So you see something, 90% of the time it's going to be X, you treat X, it gets better. But every so often you're going to encounter a problem that doesn't respond to the treatment, and then you have to consult someone. You know, if it was a sinus issue, you'd be thinking, okay, well, maybe I need to speak to Dr. Suraj about this because this is his area. If it's a leg ulcer, you say, well, okay, let me speak to one of the surgeons, you know, Dr. Burt, Dr. Cavier, Dr. Greenwich. You know, you should realize that, okay, it's not responding. Let me speak to someone.
You're talking about the patient or the person who's treating
Both of
the
them.
wound? Okay.
Both of them.
Let me put a slight different slant on it. So most of the health centers or the hospitals, the clinics, etc., would have doctors who are qualified to take care of patients. Of course, they are answerable to a more senior doctor. So usually if you're not sure of something or you've tried the same medication every time it's not working, there's always a more experienced person you can contact. Sometimes this may happen, sometimes it may not happen. But I think that hierarchy always exists. For example, you run a clinic. I used to run clinics in VH. You run a clinic, there's your junior and there's yourself. So if he or she, who's your junior, although he's a qualified doctor, do not have a little difficulty understanding, they refer to you. And you take the matter, and then if you feel that this is not in the domain of ENT, it may be more neurosurgery, then you as a specialist refer to the other specialist. But there's always this hierarchy that you refer to if you have a problem. It's just that sometimes the most I can say in the government sector, public sector, is that the numbers are much bigger and then you have less time with the patient. But apart from that, the cases that Dr. Greenwich is talking about is more like an approach to how you do it. It's not that they have no clue what's happening. It's just that the patient come in, you take care of the wound, and maybe there are about 60 patients you have to see in 4 hours.
And maybe you've never seen the patient before.
Right.
Because, you know, this is the first time you're seeing this patient who may have been coming to the clinic for a couple months. But of course, you know, doctors will have more than one clinic to be responsible for.
That's right.
So there are lots of reasons why there would be issues with, you know, getting a patient better. But I think that, you know, a rule of thumb is always, you know, call a friend. If things are not, you know, call a friend. And it doesn't even need to be a specialist. It could be the nurse who's working with you. It could be another colleague who is similarly trained. But, you know, you just you know, feel, man, this patient is not improving as I would want them to. So let me call someone and discuss it and see what they think.
And as Mrs. Richards was saying, that you concentrate on the cause and not only the ulcer. Okay, it's not a question of putting a bandage on the ulcer, clean it up and put some peroxide on it and make it look nice and pink. It is the fact, the more difficult problem is the cause of it, because the cause is intimately connected with habits, with culture, with ways of doing things, and it takes it's a long haul to get on top of it. So it's a much more frustrating exercise. So most times you just take care of the wound.
So Ms. Richards, in your case, in your work, you're more qualified to do care or cure?
When you say qualified,
experience.
I focus on both. The goal, the end goal, is always cure. So it's not straightforward, and it's by no means a magic trick. There is no, every single wound you encounter, well, I have encountered, is completely different because every patient is different. So what I would use on this patient, whatever materials that I would use on one patient may not work with another patient. So for example, there are different dressings that you can use to treat a wound. Some people would be okay with just using regular gauze. Other people might need alginate. Other people might need foam. There are different dressings. Some people might do well with a honey dressing. Other people might react differently. So it's with all things, it's trial and error. But every patient is different. Every wound is different. And caring for the wound, it starts with caring for the patient, because the patients have to feel comfortable enough to come to you, first of all. And these wounds, they're just one aspect of the patient. Patients would come in, they may be hypertensive, they may be diabetic, they may have other underlying issues. And at Bay Medical Center, we deal with all of those things. We have a general practitioner who will manage the patient's hypertension. If they don't already have a doctor who referred them to us, then we would manage them in that aspect as well. So if you have a patient who just coming to get a dressing done, yes, you treat the dressing, but then that patient is going to tell you things, and then you're going to be, because you spend a lot of time caring for a wound. It's not a 5-minute thing where you just come and I just clean it up and I just slap on no. Sometimes I spend up to an hour or more dressing one wound because it needs to be debrided. And it's not something where you can just go in and just scrape, or you can just go in and just, you have to take time and take care of the patient. These wounds are very, very painful. And even with local anesthetics, it is still something that is difficult, not only for the person giving care, but the person who's receiving the care. It is very difficult. So there's a factor of understanding the patient and helping the patient to understand what they're dealing with, and the fact that it's not going to be an overnight thing. It's going to take time. They have to understand that they need to be patient, and it's always good for them to have support at home. So in terms of managing a wound in the office, that's easy for me to do. But then I only see you, twice a week, once a month. You have to deal with this at home. So it's always good that the patient has that kind of support. And if they can come in with that kind of support, then when they're doing the dressings on their own at home, they have that support and they can be helped with it, because healthcare is not cheap. The dressings and going to get them done is not cheap. The material that you have to use is not cheap. So it's always good, and what we really focus on at Bay Medical Center is to teach the patients and their family members how to deal with the ulcers outside of the clinic, so that they can, heal faster. Because you can't come every day, and most dressings sometimes need to be changed daily. So you would not be able to go out to the facility, not even the health center, every day to get a dressing done. So it's important to teach the patients themselves how to care for those wounds themselves.
So, Dr. Greenidge, apart from genetics,
yes,
how can we avoid this kind of situation?
Well, as you said, awareness that the issue exists, sort of hygiene in terms of making sure not to stand, not to sit for prolonged periods, break it up. activities are very important. So simple things like exercise, walking is very, very good. If you can get into the water is very, very good for venous health. So, finding yourself for whatever reason at the beach, in the sea, swimming, standing, chatting to your friends, is very, very important. If you get a chance to elevate your legs. If you know that you're prone, you should wear support hosiery. So we have what are called graduated pressure stockings or graduated pressure socks, so they're not just simply a tall sock, but it's a sock or a stocking that provides a slightly higher pressure at the ankle, which gets gradually less as you go towards the knee. So it encourages the circulation to go in the right direction. And early recognition. Deep vein thrombosis is a problem that can go on to develop into this. So knowing that, for example, if you have a diagnosis, if it's a doctor that knows or the patient that knows, that the treatment of deep vein thrombosis needs to be complete. So sometimes, for example, in the past, if a person has a deep vein thrombosis, we give them an anticoagulant for 3 months, and then we say, well done, and send them on their way. But we probably should be doing more. We probably should make sure that while they're being treated, they're wearing support hosiery. We should confirm that the clot has been fully treated. So some patients will need treatment for longer than 3 months. So the guidelines will say 3 months, but if you scan them, you will still see some residual blood clot in their veins, which means that they need a little more time, because it's important to resolve the clot, because with the clot will come damage to the valves, and then come the problem of what we call post-phlebitic syndrome, which basically means a syndrome that occurs after the clot. So, as the thing is that as medical professionals, there's a lot to know, there's a lot to keep knowing, and there's a lot of change. There's rapid change. The change. For example, I gave a lecture today, and I used a lecture that I gave 10 years ago to base my talk today. I had to change half the slides because they were completely irrelevant. And I was like, wow, this is really amazing. A lot of things in medicine change, but they haven't changed that quickly before. But we are seeing a revolution of information and technology and change. And as patients and as doctors, we need to try the best we can to keep up. And it can be difficult.
So if I understand you correctly, you're saying basically to help avoid those kinds of issues, keep the body moving?
Keep the body moving.
Okay.
We come back to the same thing every time we talk, Andre.
That's true. That's true.
Eat properly and keep moving.
That's right. A few things I would like to say based on what you all have said before, and that is the emphasis of this program is primarily to educate the public generally, so they can recognize the illnesses, they can recognize the early signs of issues. For example, the ulcers, the lung ulcer is a typical example of where if you pick it up early, or you are aware that this thing is going to happen, that you're developing varicose veins, you're changing the color of your skin, your feet, and then if you pay attention to these, then, and you know that if you did not take action, preventive action, it will lead to that. I think now what is happening, you can see now the tremendous challenge you have to cure one of these ulcers. Mm-hmm. It takes the whole family involved, because sometimes somebody has to drop you to the doctor and drop you back. And it takes a lot of money, as Mrs. Richards was saying. The material is expensive. Healthcare is not cheap. And
And she also said it's very painful.
Very painful. And so I think that it is one of the examples you see where if you adopt a healthier lifestyle, if you look at monitor your body well enough to know when changes are happening, you may not understand all the changes, but seek attention. And if you have this little sore, or how you call it, a little pimple, however it started, don't take it for granted that it's nothing serious, because once the body will always react to the environment to which it's in.
What do you mean by that?
It means that the things that will happen to you will be based on the environment you're in, the culture you're in, the habits you're in. To a large extent, I keep on telling patients that from the top of my head, about 80% of the problems I see is something somebody have done to themselves or they have failed to do. It is not de novo or things that develop with you.
Not bad luck. It's not bad luck.
It's not bad luck or spirit.
Or somebody I would have jinx on you.
Yeah. So it is attesting to the vein now. Dr. Greenwich is a vascular expert, so have had extensive training in that and experience, and therefore he's seeing the venous disease in a different perspective, and that is what training is. And the other thing I wanted to say is that we are, as he was saying, he had to change half of the slides that he had from 10 years from before. What it is saying is that the science is moving in leaps and bounds. If I tell you how anesthesia started, they used to take you and strap you down and tie you down and give you alcohol until you almost half dead and operate on you.
Jeez.
But it has evolved.
If you're lucky.
If you're lucky.
If you're lucky.
And a thyroid which bleeds like mad. They used to do the thyroid without general anesthesia. You can imagine somebody in your neck doing that. And so, I know you're cringing, but I know this is where the science came from.
Extractions were
So I want
brutal. They were brutal.
I want to kind of round up the discussion here. Apart from talking about the veins, is that where science has come from and where science is moving, and maybe it'll be a time for us to do a topic on the development of medicine to see where we are going through. But it's essential to say that the medicine is a scientific subject, and with a lot of social and behavioral type of assessment that you have to do. And I would like to say that what Dr. Greenwich is doing, the approach is perhaps the approach that will eventually become the standard approach, because obviously if you have an approach you are seeing results, but I think that whatever he is doing should be done in all the healthcare facilities and begin to concentrate on it, because we are moving forward. And so I'm happy to see that he was here to explain to us, although he didn't say much about his symposium today, but that's an extremely good initiative from a single entity to come in and begin to throw some light on how we can do things differently. So I wish to thank him for that. And any particular word of advice or caution you want to ask to tell the general public, because we're just about rounding up.
Well, just to support really everything that we have been saying on a few occasions that I've been here as well with you, Leonard and Andre, that we keep coming back to this thing about, keep active and be mindful of what you eat. Mindful meaning portion size, and know the foods that we need to really try and avoid, such as sugar, salt, flour. Try to have more healthy diet in terms of less processed food, more, shall we say, natural foods. The fruits, vegetables, grown provisions, and the different meats that we have, and try to avoid a lot of the processed foods.
That's right.
social interaction. You know, make sure you surround yourself with good friends. You know,
that'll give you good advice.
People who reflect your values. You know, I think this is really important.
Okay, well,
Crystal?
any last word, Crystal, to tell the people how to take care of their wounds?
First of all, recognize that if you do have a wound that is not healing, that there is an underlying issue, and it's not always obia. It is not always diabetes. It can very well be venous insufficiency, and we do have an expert on the island who is very, very good at letting you know how to treat it, how to deal with it, and your wounds can heal. You just need to find out what's causing the wounds.
Okay, thank you very much. And I would want to add, it is not when you pass on something or when they wange something for you. We are past that stage. We're in the scientific age, and we have to look at the thing, look at how things happen and how we can prevent it. So at this point, I would like to wish everybody a good evening, and I hope that you enjoyed the program. Though people didn't call, we didn't even give them the number.
Yes,
but
that's
anyway.
true.
At the beginning, you go ahead.
And so therefore, next week, Tuesday, same time, we'll be here again. Thank you. Have a wonderful evening.
And thank you, Dr. Greenwich. Thank you, Ms. Richards. Thank you very much. You've been listening to and watching on Facebook and on YouTube, Doctor in the House with Dr. Leonard Suraj. Listen again next week for another Doctor in the House from 6 p.m. to 7 p.m. with Dr. Suraj with the compliments of Tapio Hospital.
At Tapio Hospital, we operate a 24-hour emergency service for all your urgent healthcare needs. Our qualified medical specialist will be on hand to ensure that you receive the best of care. Call us at 459-2